Just sort of read a little excerpt out of here at the beginning of the book. You talk about how there's no escaping the tragedy of life, which is that we're all aging from the day we were born and may even come to understand and accept this fact. But then you talk about how medicine deals with the fact that we're all going to die, and you say this, you say, this experiment of making mortality a medical experience is just decades old, it is young, and the evidence is it is failing. What do you mean by that? How is it failing?
Let me tell you about a study of which there are a number of these, but it brings it home. Well, there are two studies. Let me tell you two. One of the things I came to recognize that the folks who were able to manage this process much better recognize is that people have priorities besides just living longer. They have priorities of, just surviving in the world is not enough for most of us. We want to know that we have a certain quality of life, and that might mean that we really care about another priority, like whether our brains are intact, or whether we get to be with family, or whether we get to hang out with our dog. It's different for each person. The most reliable way to find out what people's priorities are is to ask. And we don't do that. So study number one, it's a trial of cancer patients. It was a study of patients who were in a trial across the United States. They were all stage 4. They lived on average only 4 months more after the study started. And less than a third had a discussion with their doctor about what their goals and priorities were as they faced the end of life. Less than a third. The third who did ended up being more likely to not end up in the hospital towards the end, to be more likely to have less suffering at the end of life, more likely to stop aggressive therapy sooner, and their family, 6 months after their death, were less likely to have post-traumatic stress disorder symptoms and have major depression. There's a second study, which was, of which there have been multiple other ones that have confirmed these kinds of findings. At the Mass General Hospital, they treated their stage 4 lung cancer patients, with half of them getting oncology care the usual way we would do it, and the other half not only seeing an oncologist, but seeing a palliative care specialist to talk about what their major goals are if and when their health worsens. The group who had those conversations ended up, just like in that other one, less suffering, started hospice sooner, stopped chemotherapy earlier. 30% less days in the hospital and less chemotherapy. Again, less suffering, more time on hospice. And they lived 25% longer. Which means we're just making bad decisions.